We live in a constantly changing world where the speed of information is changing how we think and act and connect with one another. When people in a society lose faith in their institutions, in God, and in each other, the nation collapses. We need help rebuilding trust and tying it all together. Welcome to All That to Say, a podcast exploring the interrelatedness of all things in long-form conversation. Former Surgeon General of the United States, Jerome Adams, joins Jim Lyon to discuss COVID, creating space for those who disagree, and how representation matters.
Dr. Jerome Adams, lately the Surgeon General of the United States. We're so glad to have you at our table. Thanks for coming alongside. And when I think about the Surgeon General, I just have this vision of somebody all buttoned up in a military uniform. It has a certain kind of military frame to it. And I think that goes way back to the dawn of the Republic when it first was imagined. Tell me about the Surgeon General. When we talk about Surgeon General, does that general mean you get to be the rank of a general? Or is it more like, no, you're generally the surgeon? What would you say?
Well, fantastic question. And when people think of a Surgeon General, they often don't think of someone who looks like me, a younger-looking African-American man. And that's been, quite frankly, a challenge, is overcoming some of those stereotypes. But I often tell people I'm the Surgeon General, but I'm neither a surgeon nor a general. I'm actually an anesthesiologist, so I've worked with a lot of surgeons. And the Surgeon General has a rank that is equivalent to a general, but I'm actually an admiral. So the office of the Surgeon General was started back during the time of John Adams. The Public Health Service was started to inspect ships as they came into port.
It was a marine kind of hospital. Maybe that's why the naval motif goes through.
And so the Navy would actually go out and stop these ships, and then our officers would go out and inspect them to make sure they weren't bringing in infectious diseases. And we adopted naval rankings. And, the interesting thing is that that's how the service was started several hundred years ago. And today, we're still trying to stop infectious diseases like Ebola, like Zika, now like COVID, from entering our communities. And so what's old is new again.
Wow. And, as you're just describing that, it makes so much sense, honestly, because sometimes I think we kind of just drive by positions and offices. We know there's of substance. We know it's a real thing to be a Surgeon General, but what's the history of that? You just opened up my eyes to the reality of 18th century America where ships are coming and somebody's got to check them out.
Well, one of the most memorable trips that I took was to Ellis Island. So every single person who came into the United States through Ellis Island was inspected by a public health service officer. And it was this 15-second exam that they would do. And you think about this, in 15 seconds, from a clinical point of view, you had to look at someone and determine whether or not they were fit to enter the United States. Wow. But you also think about, again, the heavy weight that is on public servants, that's on doctors, it's on nurses. You could truly change a person and an entire family's trajectory.
Their whole history.
By 15 seconds. And so it was a very powerful trip that I took. And when you think about all that entails, one of the other challenges of my job is just simply explaining to people what I do and what I don't do. For instance, a lot of people think that I'm the president's doctor and that I have an office next to him in the White House. The truth is that I rarely saw the president until we got into this COVID situation where we were having to do daily briefings because the president's got a lot of other things going on, and my office is several miles away from the White House.
Your office has a lot of other things going on too.
Exactly, and we're doing a lot of things too. But I tell people, number one, I lead the Public Health Service. So I am a Vice Admiral, or I was when I was the Surgeon General, and I oversaw 6,000 uniformed officers in the Public Health Service. So we're one of 8 uniformed services. Army, Navy, Air Force, Marines are the ones that everyone gets. Coast Guard's the Jeopardy question. But then there's the National Oceanic and Atmospheric Administration. There's the Public Health Service, and there's the new Space Force.
Okay.
So I was the CEO of a 6,000-person company. That was one job that I had, which alone would be a full-time job. But then I also have the role of being the nation's doctor, trying to help America understand how to be healthy.
And it's my understanding that the Surgeon General doesn't actually have a lot of leverage on public health policy per se, but has long been recognized as kind of a voice, an influential thought leader, we might say, in public policy on public health, right?
Well, here's something else interesting that I bet a lot of your listeners aren't aware of, and that's that the Surgeon General used to have a lot more policymaking authority. The Surgeon General used to be over the National Institutes of Health, used to be essentially equivalent to the Health and Human Services Secretary. And politically through the years, there were political struggles, both within government and between government and external entities. And many people thought the office of the Surgeon General was too powerful. And so they gradually eroded away many of the actual policy-making authorities that the Surgeon General had and the funding. And one of the biggest ironies is that Surgeons General, modern-day Surgeons General, were compared to C. Everett Koop. But one of the things about C. Everett Koop is that he was so powerful and wielded his authority in such a, I think, tremendous way that he almost set us up such that we could never have another person like him, because political parties on both sides decided we can't ever have a Surgeon General that powerful again, and took away funding, took away staffing. I often say this to people so that they understand it. I used to run the Indiana State Department of Health, and you and I are in Indiana right now.
Yes.
When I ran the Indiana State Department of Health, I had a staff of about 1,000 people that I oversaw, and I had a budget of $300 to $400 million. As Surgeon General of the United States, I had a budget and staff that were less than 1% respectively of what I had when I ran the Indiana State Department of Health. But yet, I'm supposed to be in charge of health policy for the entire country in people's minds. And so not a lot of funding or policymaking authority, but a very, very large bully pulpit. And it took a while to figure out how to wield that. But you can change a lot of what happens in this country and in this world by effectively utilizing that bully pulpit.
Oh, absolutely. I mean, it's a main stage, and you walked out onto it. And as I'm just sitting across the table from you, Dr. Adams, I feel like Darth Vader. And I want to say to you, I am your father, because I am old enough to be your father. And I'm looking at your resume and thinking, man, how did that guy get so much done in a lifetime that's young enough to be one of my sons? Because you've been on a rocket ship of a kind, zooming through a career path. So, I mean, let's go unravel this back to the beginning. You are a leader, and Dr. Adams, your term as Surgeon General has not long ago come to a close as there's been a change in the White House administration, which is a kind of an ordinary pass the baton, I guess. But
well, actually, it's not, and we can talk about politics later too. But the Surgeon General actually is supposed to be a term position.
It's a 4-year term, and yours is cut short.
Mine was cut short.
Well, let's just do that right now. So, I mean, since we're there, so you had a term. It's being cut short as the new administration came in. And asked you to step aside, right?
Exactly.
And you're saying that's not always the way it goes.
Well, that's not the way it's designed to be. You really want your Surgeon General to be objective, to be apolitical. And you and I have talked about this a little bit, but one of the major challenges I faced was that I wasn't trying to be the Surgeon General for Republicans or Democrats or Black people or white people or rural areas or urban areas. I was trying to be the United States Surgeon General. And unfortunately, there is less and less space in this world for someone who doesn't take a side. And one of the biggest complaints that I get still on Twitter right now is not for something that I did, but for people saying you didn't take a side. And so you end up then taking fire from both sides. But I hope that we can get to a place where we can depoliticize some of these public service positions, because they shouldn't be seen as Democratic positions or Republican positions. It really frustrates me that that Dr. Murthy is seen as Obama's Surgeon General, and I'm seen as Trump's Surgeon General, and they politicize it even when there was a newspaper headline yesterday, or a CNN headline yesterday, where it says Trump's Surgeon General. And I would always correct people and say, I was appointed by President Trump, and I am thankful for the opportunity, but I am the United States Surgeon General.
Yes.
And I hope, again, that we can get back to that.
I hear that. And you know what? Let me just postpone a little story about your trajectory. And let's go right there. I mean, you came to the stage as the Surgeon General of the United States. You were, before that, in Indiana as the Public Health Commissioner, as you've described, and you get a call one day. Tell me about that. I mean, out of the blue, or you knew this was coming? How did that work?
Well, again, God works in mysterious ways. And if you had asked me, well, it's interesting. I mentor a lot of young people, and I think one of the biggest problems to the young people listening out there is that everyone tries to convince you you've got to have everything figured out. What's your 5-year plan? What's your 10-year plan? And that you somehow are doing something wrong if you don't know exactly where you're going to be 20 years from now. But what I say to young people is, if you ask most successful individuals out there if they knew 20 years ago what they'd be doing right now, 99.5% of them are going to tell you absolutely not. If you go to 10 years or even 5 years, I've changed jobs every 3 to 4 years in my life, and that's actually the norm nowadays. It's not the norm to have it all figured out and go on a trajectory. So I never dreamed I would be in this role, much less, and I joke about this with Vice President Pence. I never dreamed that this young black guy from the East Coast would end up being so aligned with a gray-haired white guy from Southern Indiana, but what we were, and so I had the opportunity when I was in medical school to get involved with organized medicine, American Medical Association, American Society of Anesthesiologists, and I would go to the State House and I would go to Washington, D.C., and I would talk to our leaders about what I thought we needed to do to improve health and to improve support for clinicians, for doctors, nurses, et cetera. And so when then Governor Pence, Indiana Governor Pence, needed a health commissioner, someone threw my name in the hat. And, otherwise I would have not known him. I would have never come across his radar, but God put me in position A, or opened a door, and I walked through it, and that afforded that opportunity, that introduction. And I went in and I interviewed with him, and I still remember this. First thing he says to me is, "Gosh, you look young." He did exactly what you did. He looked at my resume, and then he looked at me, and he wondered if he had the right guy. But we talked, and he offered me the job. And on day 2 of the job, I had to stand next to him and explain how we were going to deal with the emerging Ebola crisis. And so we dealt with that. We had an HIV outbreak in southern Indiana, the largest HIV outbreak related to injection drug use in the history of the United States. And that is, I think, how I got on the national radar screen, because that was tough. We took some hits, and
tell me, took some hits. Why?
Well, we took some hits because there are a lot of people who felt that we didn't act quickly enough to institute a syringe service program in southern Indiana. And what I often explain to people is that, A, they were illegal at the time, and so you couldn't just do it. And B, you had a lot of cultural community pushback against these kinds of programs.
Well, and you have to help us define that too. A syringe program, meaning
Yes.
provision of clean syringes.
Exactly.
Because that was a transmission vehicle for the HIV.
Exactly.
But it suggested to some segments of the public that was encouraging unhealthy use of drugs and so on. Is that the idea?
That was the concern. That was the concern that people, including my own family, had. And I've talked very publicly about my brother's struggles with substance use disorder. And there are a lot of people out there who did and still do feel that you are enabling substance use when you give people these syringes. But what the science shows is that when you give them clean syringes, you not only disrupt disease transmission, but you form a bond. You create a relationship. It's an opportunity to sit down with someone and talk to them about treatment, talk to them about the resources that are available. I mean, and I don't want to make it sound like I'm more religious than what I am, because I believe in God, I believe in Jesus, but I struggle too, so I don't want to make it seem like I'm out there quoting the Bible all the time, but I did very much think about that and the fact that Jesus sat down with some of the people who were considered the worst in society at the time, and he did it because that's how you build that bond. And so when I went down to southern Indiana, I had to sit down and break bread with the community, with the sheriff, with the public health officials, with the business leaders, and form that relationship. And once they trusted me, then we were able to talk about a syringe service program, and then the community supported it. Because if they hadn't, and if I just used my authority as state health commissioner to open a syringe service program, the sheriff would have set up a roadblock outside my syringe service program, arrested the first person who came in to it, and no more syringe service program. And so, you form those relationships. And I'm actually very proud of the work Scott County did. And I was proud to be a part of that work, because after Indiana opened up a syringe service program down there, Kentucky went from 0 to over 50 syringe service programs. Ohio doubled their number of syringe service programs. There are thousands of cases of hepatitis and hundreds to thousands of cases of HIV that have been averted in this country right now because of the work that Scott County did. But it started with relationship building. One of my favorite sayings is people need to know that you care before they care what you know.
That's exactly right. And this is your kind of introduction to public health in official office capacity, is managing that crisis. It was a crisis.
It really was.
And the outcome was that the crisis subsided.
Exactly. Well, the crisis subsided, that syringe service programs were now legalized in Indiana, but in many other places in middle America and rural America and conservative America, and that we actually changed systems. Federal law was changed to allow funding for supportive syringe service programs because of what we did. And I'm passionate about this story because, again, it shows people that sometimes change takes a while. Sometimes it takes longer than what you want. But if you don't take the time to build those relationships, then change either isn't going to happen or it's not going to be long-lasting. And
this whole episode puts Dr. Jerome Adams, Public Health Commissioner in Indiana, in a higher profile.
Well, exactly. On the national radar screen, Time magazine, President Obama at the time was getting daily updates about the HIV outbreak in southern Indiana. We were really the canary in the coal mine, if you will, where the United States and the world realized, hey, we have an opioid epidemic here, and it is impacting everyone. It's impacting places we never dreamed of. Even the CDC, the Centers for Disease Control, had to change the way that they allocate funding and resources because guess what? A rural, mostly white community in southern Indiana was never on their list of at-risk places for an HIV outbreak.
Nobody saw that as a drug center. Our video jockey, Matt Derby, is picking up some headlines here. Who is Jerome Adams? and help us connect the dots. So from HIV infection spread by needles reused,
yes,
right? Opioid, the reason that the needles are being reused is because opioids are involved in the injections, right?
Exactly.
This is how it all works together.
Exactly. My own brother, and I've been very public about this, struggles still with substance use disorder. And one of the things that helped us understand was not just that the opioid epidemic was bigger than what we thought, but that we can't look at someone and determine if you're at risk or if you're misusing substances. I was the Surgeon General of the United States. I grew up in the same house as my brother, who has been incarcerated for substance use disorder. So you can't say it was a bad home. You can't say it was bad parents. You can't say it was a bad upbringing. Anyone can, unfortunately, go down that pathway. And for my brother, for instance, it was unrecognized, untreated, stigmatized mental health issues. anxiety and depression. And he self-medicated, first with tobacco and alcohol, and then he moved on to marijuana. And then one day he went to a party, and he'll tell you someone gave him a pill and it was like a light switch went off. And that is how quickly you can become addicted to opioids. And so I've spent a lot of my recent years in public health really trying to destigmatize mental health issues and destigmatize substance use disorder and destigmatize the treatments and the remedies for substance use disorder, because there's stigma against even admitting you have anxiety or depression. Pull yourself up by your bootstraps here in farm country. There's stigma against being labeled as an addict, and I use that word intentionally because it's a word that we try to discourage people from using because it's a stigmatizing word. But I really want your listeners to hear me when I say it, that's something that when you call someone an addict, there's an image we all have in our mind. And it's this image of this person who is not someone who we think of ourselves as being. And so we're trying to separate that image that we have in our head, that stigma, from the reality that most people out there with a substance use disorder are people who had good upbringings, who had challenges, mind you, but who are just like us, or who could be just like us, but for a turn here or a turn there. And the treatments of syringe service programs, naloxone. As Surgeon General, I put out an advisory calling on more Americans to be willing to carry naloxone. And this was something that shocked me to the core as a Christian, was how many people out there were against using naloxone to prevent someone from dying of an opioid overdose.
Naloxone. What do you mean?
Naloxone is a medication. It's an opioid overdose reversal agent. So if someone takes too much heroin, too much fentanyl, too much of an opioid, the people who die, they die because they stop breathing, their heart stops. And naloxone is a medication that binds to the same receptors that the opioids bind to in your body and pushes the opioids off so that you start breathing again. And that's usually the main way that it prevents people from dying. I want you to think about this. Once upon a time, there were people dying in the streets from cardiac arrest, from heart attacks. And we discovered that we could teach people how to administer CPR. And now if you go into a room of 10 people, it's hard to go into any room of 10 people in the United States and say, raise your hand if you know CPR, and not have one person who doesn't know CPR. But that wasn't always the case. Well, now in communities like the one we're in right now in Anderson, Indiana, you are more likely to encounter someone who's having an opioid overdose when you're walking down the street than you are to encounter someone who's having a heart attack. That is the reality in far too many communities across America, and Anderson is not unique in that respect. So I wanted people to think about naloxone the same way they think about CPR. It's something that anyone can carry, anyone can administer, and you can save a life. But I was shocked at how many people out there were of the mindset that was enabling people. How is saving someone's life encouraging them to go out and use again? The problem wasn't that we saved their life and they were just going to use again. The problem was we had to save their life first, but then we had to connect them to care and treatment and meaningful evidence-based treatment. And so I used my bully pulpit as Surgeon General. The very first thing I did was craft a Surgeon General's advisory on naloxone. And we were able to increase naloxone prescribing in the nation by 400%. So very proud of that work. Proud to be able to use my bully pulpit to destigmatize naloxone. We're starting to destigmatize treatment, medication-assisted treatment for substance use disorder, because that is a evidence-based way to help someone recover. But again, stigma kills more people than cigarettes. It kills more people than heroin or fentanyl. It kills more people than COVID. And I think we all need to try to normalize the fact that we are all less than perfect individuals, mentally, emotionally, and physically. And that we shouldn't look at someone and think of them as bad or being at fault because we've not walked in their shoes.
Well, even just the vocabulary substance use disorder is a turning of the page, because there is a lot of judgment and preconceived notion, prejudice,
Exactly.
when people struggle with some kind of substance abuse. And I think we all understand that there are choices people make, but not everything is consequent to a choice that they've made.
And the choices that people make are 100% dependent on the choices that they have in front of them.
That's right.
I had this conversation with my daughter today. I said, you're very fortunate. Your father is a doctor. He's not just any doctor. He's the 20th Surgeon General of the United States. And you have choices that some of your schoolmates, classmates, friends may not have. And that's not something for you to feel guilty about, but it is something for you to be aware of and recognize. And so we can't, through our privilege, be blinded to the fact that other people didn't have the opportunity to make those same choices. Other people have adverse childhood experiences, and we know that if you have more than a few adverse childhood experiences, the chances of you misusing substances, dropping out of high school, ending up in jail or for committing a crime, they go up exponentially. And so we need to figure out how we protect children, but also how we build resiliency into our systems so that children can recover even if they've had an adverse childhood experience.
This whole conversation just is reminding me of a conversation I had with one of my sons who lives out in Seattle and has spent the last few years of his life working with a homeless relief ministry. And he kept telling me, Dad, they're not homeless. They're people who live outside. And I didn't catch it at first, but then he unpacked for me, there's a lot of stigmatization about people who are homeless in the popular vernacular. And often there's a run to, well, they're homeless because they have been irresponsible or they have lost themselves in some kind of substance abuse or whatever. I mean, and yet, in fact, in many of our urban centers, there are many people who are homeless consequent to other economic factors and things beyond their control. They may even be working, but living in their car, but they can't make a sustainable wage because they're not educated for it or whatever. Anyway, the whole vocabulary of me going home to Seattle to visit, which is my original home and my family still has roots here, to drive by and realize, those are people who live outside, changed the way in which I thought about what could I do to help address this thing. And I've just resonated with what you're saying. Substance abuse disorder is a way of just a step towards saying, wait a minute, there are ways that we can help instead of just writing off or dismissing or imagining, you've made your bed, now you have to sleep in it, which is sadly where many times we respond.
Well, and I love that you said that, because some of these problems seem so big that it's hard for any individual to think, what can I do? But one of the things you can do is be cognizant of the words that you use and the times when you are either perpetuating stigma or busting stigma. Addict, homeless. So many words that we use, even obesity. There is a lot of shaming that goes on with obesity, but in many cases, there are adverse childhood experiences, there's mental health issues, there's trauma that causes people to self-medicate with food. Mm-hmm. And so you're looking at them saying it's all your fault without realizing that that was, in many cases, a reaction to terrible traumas that people faced, or just an inattention, an inability, a lack of access to mental health services that could have put them in a better place mentally and physically.
Or not even sure what to do.
Exactly.
Because sometimes you get so far down a road, you're not sure that there is a way back. Well, as we've talked about these things, you found yourself in an increasingly higher profile, doing good work here in Indiana. And then one day somebody says, Dr. Adams, do you want to be the Surgeon General? How does that come down? How did that develop?
I mean, surprisingly, that's exactly how it happened. Vice President Pence called me on the phone and said, hey, you want to be the Surgeon General? And
did that take you by surprise?
It did. It did, because I never dreamed that I could be. I never even dreamed I could be a doctor. I actually had good grades. Both my parents were school teachers. We grew up poor because school teachers don't get paid well, and we were a family of 5. But education was always important to me and my family, and so I had 3.9 GPA throughout high school. Really, on paper, could have done anything, but I never met a black physician in my life until I got to college. If you don't see it, it's hard to be it. And so it wasn't until I got to college and I actually met Ben Carson. Oh. Now, he was the first African-American physician that I had ever met. And I know some of your listeners, just statistically speaking, will love Dr. Carson and some will hate Dr. Carson. But I want you to understand, some of your listeners love me, some of your listeners hate me. And that's just a fact. But I want people to understand representation matters. It's important for people to see someone who they can relate to. And one of the privileges of being Surgeon General was not just being an African American Surgeon General, but being a Surgeon General who grew up in rural America on an old farm, being a Surgeon General who has roots in Indiana and can represent Middle America, not just someone who's from the coast. But yes, I was shocked when I got that call, and what I said to him was, I have to ask my wife. Because my wife is from Indiana. She had never lived anywhere else. And
she grew up on a farm, too, in a rural environment.
Yes. One of our favorite things to do still is to go to my in-laws' house, her parents' house, and take the kids. And they go out and they get fresh eggs from the chickens. They go out in the cornfield and pick ears of corn and go out and throw them at the chickens and squeal while the chickens are,
Not so much of that in Washington, D.C.
Not at all. Not at all. And so my wife actually, to her credit, because I thought she was going to say, no way, no how. My wife said, well, if this isn't a sign that you should be using your talents in this way, then I don't know what is. And so she very much supported me, even though she's also said very publicly that if you asked her what her idea of HE double hockey sticks would be, it would be packing up her 3 kids and moving across the country to live in Washington, D.C., just because it's so different than what we've become accustomed to and what our kids and she have known in Indiana.
As you're telling me that story, this is a trivial pursuit, but I'm fascinated by history and biographies, and I read a biography of Pat Nixon. And, of course, she lived quite a tumultuous life. Her husband was up and down. But somebody asked her once about her journey to Washington, D.C. and all that happened. And all she said was, well, it's not the life I would have chosen, which I thought was a great gift of understatement. But you're demonstrating, as Pat Nixon experienced, that sometimes your family is called to some place or to do something, and your wife supported you in that and became a part of that team going there. But you also experienced a challenge as you're moving from Indiana to D.C. in your own wife's health. What happened?
Well, about a month after my wife and kids moved to D.C. So I moved out in September when I got confirmed. The kids finished that first half of the school year, and then they moved out over Christmas. And around January, February, my wife noticed a mass in her leg. And wintertime, we thought it was a lymph node cold virus. We blew it off. A couple weeks later, it was still there. She went in to get it checked out, and the very short version of a much longer story is that we found out that she had metastatic melanoma.
That's very serious.
Very serious. I will tell you that 10 years prior, or even 5 years prior, the degree of spread she had would have been almost certainly a death sentence. And again, the Lord works in mysterious ways. Being out there, we were near the National Institutes of Health, and she was able to get into a trial, and was able to get access to new medications called immune modulators and immunotherapy, and she was successful with her treatment, and the cancer went away after about a year of treatment. We were doing fine. Then it actually recurred yet again. And we're now in the midst of treatment again for the recurrence. And things are going okay, but I might not have a wife right now. My kids might not have a mom if we hadn't had that disruption in our lives that took us to Washington, D.C. and put us in a position not just to serve, but to also have that treatment available.
Opportunity that might not have been available. Even though there's great medical care in Indianapolis, Washington, D.C. is the center of the universe when it comes to the latest technology. And the National Institutes of Health, yes, what a story. We will pray for your wife.
Please.
Because still on the journey.
Well, for my wife, for the kids, and you hit on a point that I think is important for your listeners. We talk about public service and public servants, and it is critical to me that people understand the importance of finding out how you can serve. And it can be as Surgeon General of the United States. It can be as an individual carrying the naloxone. It can be as someone choosing the right words to use so that you don't stigmatize someone around you who you don't realize is suffering. We can all serve in different ways. But I also want to add to that none of us serve alone. And when you take on positions like the one that you're in, like the one that I'm in, our families serve too. They share in our joys, but they also certainly share in our travails and our challenges. And my kids, again, last night on TV, there were some people saying some not so nice things about me on CNN, and my daughter says, "Daddy, they're talking bad about you on TV again." My wife is taking care of 3 kids and undergoing cancer treatment. God bless her. But while I'm trying to be Surgeon General of the United States and take care of everyone else.
Here's the headline from just yesterday about a statement you made about the vaccine protocol.
Exactly.
And people jumped all over it.
Well, and they jumped all over it, interestingly enough, for largely political reasons, because, and I don't want to get political here. I'm trying to depoliticize the situation, but the statement that I made was that we should be thinking about giving states the flexibility to consider giving more vaccines as an initial dose versus holding on to vaccines for a second dose, because the studies show that 2 doses is 94% effective, but 1 dose is 92% effective. We at least need to ask that question. And this question was actually brought up by Michael Osterholm, who's a famous epidemiologist who advised the Biden team. So this wasn't a political...
It wasn't out of nowhere.
It wasn't out of nowhere. It wasn't a political statement. It was hey, there's emerging science that says we should at least talk about this as an option. And the attacks largely came at me through a political lens. And I just hope that we can get back to a place where we can have regular conversations about things that matter. Everything now has become politicized. Where your kids go to school, whether or not they should go to school, whether or not you should get vaccinated, 1 dose, 2 dose, whether or not you should wear a mask. These are conversations that we should be able to have as human beings and as scientists based on what's best for our community and what the science says, not based on which political party you're a member of.
Which brings me back to your entree to D.C. You find yourself with your family relocated to this center of the power play universe. You're taking on a new role. You get a uniform. You get a rank.
An expensive uniform. And don't at all want to say poor me, but a lot of people don't understand that, again, there are real monetary costs to public service. I had to buy all those uniforms myself.
You have to invest in them.
And my wife actually, I remember her saying, "Honey, what's this $3,000 charge on the credit card bill?" As we're moving in across the country, and
sure.
The bills are racking up. And I said, "Well, that's my uniform." And she said, "They don't pay for that?" And I said, "No, honey, they don't pay for that." So I have the uniform still. The uniforms, there are multiple different uniforms that you have to get.
But you own them outright.
I do now, and you can better believe that my wife is going to make sure we find some use for them in the future.
Well, I mean, it's a lot of adjustments on so many fronts, but you're also thrown into a cauldron, which, while there are politics in Indiana, I know about that, in every state, every place, suddenly you're in the center of the political universe. How did you find that? You mentioned to me once before we came to the table here today about how, there's a certain relational, transactional nature of life in D.C. It doesn't matter what side of the aisle you're on. There's just this kind of way of doing things that must make it hard to navigate. Who do you trust, and who wants what, and how do I navigate? Did you find that challenging?
I found it incredibly challenging, because one of the things that people either love or hate about me is that I'm very open. I wear my emotions on my sleeve. I talk about things the way I would talk to my mother or a neighbor, very plain spoken. I don't try to go out there and act like Dr. Adams. I go out there and say, hey, it's Jerome, your neighbor. I went to medical school. Here's what you should know about vaccines. And I try as much as I can not to shame anyone. Again, shame, stigma, those separate us. Those push us further apart. And again, the biggest complaint that people often have about me is that I refused to condemn other people. But I've always taken the approach that if you can find something in common with people, if you can bring them into the fold, if you can build trust with them, you are going to be a lot more successful in convincing them to change their behaviors than by trying to shame them into changing their behaviors. But DC is a world where there's very little quarter for people who don't take sides. It's almost an instant calculation. In Indiana, people will ask you, what town did you grow up in? Where did you go to high school? Out in Washington, D.C., it's where do you work? And it's almost an instant assessment of which political party you are.
And then you're sized up.
And then you're sized up. And then a caricature is created of you in their mind. And so many people have this caricature of me based on a snippet that they've seen on Twitter or a blurb on CNN or just something that they heard from a friend. And that's why I appreciate this opportunity, because I try to help people understand. I grew up poor. I grew up rural. I grew up a kid with asthma. One of my proudest moments was when I stood at the White House and in between the president and the vice president of the United States and spoke to America at a press conference and held up my inhaler, because I know how stigmatized people with asthma are. I knew growing up how I was bullied because of my asthma. Even now, when you look at TV shows, one of the things that frustrates me is if they want to show a kid as being weak or nerdy, they show him pull out his inhaler.
That's the emblem. Yes.
Exactly. Yeah. And so I try to be very open about my vulnerabilities, my family's vulnerabilities, because I wanted people to understand that, hey, there's someone like you here fighting to make sure you're heard and fighting to make sure you're thought about when we're making these national policies.
And of course, as we've talked already, you came to the job already with a passion to address the opioid crisis. Mental health issues are important. I mean, those kind of weave together. They're separate issues in some contexts, but also side by side in others. And then, as you're doing your job, there is the pandemic, the COVID-19, which overtakes everything, it seems. It has to be a kind of a detour from what you dreamed of. I think about George W. Bush coming to the White House. Most people don't realize in the year 2000, he was elected to be the education president. But 9 months in, there's the 9/11 attack. And suddenly his whole trajectory is altered. In a similar way, your trajectory also was altered by this crisis, national crisis. I think most people, Dr. Adams, would recognize you from that epoch, that period of your service. And let me just say thank you. I mean, seriously, thank you for your service, because just as you've described the costs and the disruptions, and maybe there's the benefit for your wife's health and so on, but nevertheless, it's no small thing to do what you have done for the public good. So thank you for that. Most people wouldn't see all of that, except that you were put on stage. You became part of the lineup of the task force that became so much a fixture in a season of our national consciousness. And I just have to, if you're game, tell us about that. So let's say we're doing there was that series of weeks where there was a daily briefing with the president and the task force. What's happening as you walk down the hallway to the press briefing room? Oh, and I just have to say, I had the chance to visit the White House a few times, and in fact, just a year ago, December, I was in that White House briefing room, and most people who have not been there cannot imagine how small it is.
Yes.
I mean, it is really tight quarters. And with a pandemic, it has to be spaced out differently. But I mean, it's kind of a modest space, really. But on television, when you just see the podium, it seems like it's a grandiose.
Isn't that what we all do with our Zoom calls now? If you see what you see on the screen versus what's going on in the background.
Well, let me say, some people should take a tip on that in their Zoom calls. I've seen some stuff in the background you don't want to have. That said, what's it like walking out there? Is there a prep? Is everybody agreeing about where this is going to go? Or you just kind of go out and wait to be asked a question?
Well, we would have our daily meetings of the task force. And the vice president would usually run those, and you'd have Tony Fauci, Deb Burks, Dr. Redfield, the CDC director, Steve Hahn. But you'd also have other cabinet secretaries there, because what people, I think, really have been forced to reckon with is that nothing exists without health, and health can't exist without all these other things. Transportation, shut down because of COVID. The business community, deeply impacted by COVID. Housing, one of the biggest risk factors for spread of COVID is multi-generational housing. So we had to have Dr. Ben Carson there, head of HUD. So we'd all sit around and have 90 to 120-minute meeting about where we were, and we'd walk through the data. Dr. Burks would walk us through the data, and then we'd discuss whatever pending topic there was, different policy issues. Were we going to put out a recommendation for X, Y, or Z? And then at the end, based on the discussion and the policy recommendations and what we felt we needed to communicate to America, the vice president would say, okay, you, and you, please come out and with us to the press conference. And so if we were going to have a transportation announcement, hey, we're shutting down flights back and forth to Europe, then the transportation secretary would come out. So I would end up out there probably, I'd say on average, once to twice a week. And you typically, the vice president would say, I want you to come out and talk about this particular facet that we discussed. And most of the time, I was tasked with helping to highlight disparities, inequities, and the things that we were doing to try to make sure, for instance, our Native American and tribal brothers and sisters were getting the resources that they needed, that we were collecting data on the pandemic according to demographics. And I did a lot of work behind the scenes to try to make sure we could improve our data collection. And that's where my focus was. But when you're walking out, it is something that is, I'll never forget it, You're walking out, and they've got all these TV cameras and reporters, and it's like Daniel walking into the lion's den. And I know many of them. You develop a relationship with them. You get there a little early. We'd go out first, and then the president or vice president or both would come out. So you'd shoot the breeze with the reporters a little bit. You had to be a little guarded because the cameras were on, but you'd shoot the breeze with them a little bit. But you never knew where the questions were going to come from. And that was one of the biggest adjustments and shocks for me, was that I was going out there to be Dr. Adams and to answer medical questions. And more often than not, it was a politically framed question, or a question that was seeking to pitch you against some other entity. Do you agree with what President Trump said or did? Do you agree with what Joe Biden says or did on the campaign trail? And I'm thinking, I just want to tell people why they should be wearing a mask. I just want to tell people where we are in vaccine development. I just want to have a conversation with people about what they should be expecting in regards to the pandemic. So it was a chess game. You go out there with prepared what you want to say and what you want to communicate, but you usually at most would have 2 or 3 minutes to give your proactive spiel. And then after that, you're just reacting to the questions that are being asked. And if you pivot, then the headline is Surgeon General refuses to answer question. Right. If you answer the question and take the bait, then then they don't cover at all what you wanted to put out there. So it was tough.
Yeah, that's a impossible scenario in a way. Now, I have to disclose something here as a way of asking this next question. So you wouldn't know, but I grew up wanting to be in government. That was my ambition. I just dreamed of being in politics, and I had my course all set. 2-year, 5-year plan never works that way. But
I still don't know what I want to be when I grow up.
Well, I'm with you. I'm still trying to figure it out, and I'm your father. But I wanted to be the mayor of Seattle, and then I'd be the governor, and then I was to be the president. I mean, I was it's preposterous now, but I'm just saying I grew up with that kind of game. So today and through all these years, whenever I watch the news or I see a news conference, I have this secret thing inside of me. I'm ashamed to say it, but I just think like, get off the stage and give me the microphone. I could answer that better. Now, I'm telling you that to say, how about you? You're at the press conference. Did you ever find yourself watching others answer questions and think, man, I've got the answer to that one, but I don't have the mic?
Well, that was one of the great things about the team that we had. And we were all good friends, Dr. Birx, Dr. Fauci, Dr. Redfield, and none of us had a problem saying, that's a question about virology. That's a Tony Fauci question. Or Dr. Adams, Jerome's been working on the disparities piece, or is the head of the public health service and can help talk about those issues. Or Dr. Birx, she really knows the data inside and out, and she's the best one to help you understand what the trends look like. So we really did work well together, but that's the actual questions of substance.
Yes.
Or of relevant
of
substance
expertise.
Of expertise to us. The challenges, again, and where that came up was really when you would get these curveball questions, and we got way more curveballs than what we got fastballs down the middle. And you're sitting there, and it was painful to sit back and watch each other have to try to, return serve on a question that was completely unfair or completely came out of nowhere. And you're in your mind trying to slow down time and ask yourself, okay, do I answer the question even though it's built on a completely false premise? Do I spend my time debating the premise? Or do I just ignore the question and pivot to something that I think the American people need to hear? And like I said, there are pros and cons no matter what. So it was always challenging.
Can you give me an illustration of a question you think unfair? Or what's the context of an unfair question?
Well, for me, again, it always, and it's different for each person, but for me, it always came back to why won't you condemn? And I will do a really quick but a somewhat deeper dive on a complex issue, and that's what do you tell people who are gathering? And I've had the pleasure of going around the country. There are people who will remember for the rest of their lives the day that they got to see the Surgeon General of the United States, the President, the Vice President. And so it is something that I really approach with caution to condemn someone for saying they're going to go to a rally and exercise their right to assemble, their constitutional right. And I would get it from one side. Why will you condemn the rally? But then a different station would ask, will you condemn the Black Lives Matter protests? Why won't you condemn the people gathering for Ruth Bader Ginsburg's vigil? And no matter what answer you gave, you were ripped apart for it. But my answer was always consistent. The virus doesn't care why you're gathering. The virus will prey on you if you don't wear a mask, wash your hands, watch your distance. And I recommend that people take these things into account so that they can make an informed decision about whether or not they are going to gather, and if so, what precautions they're going to take when they gather. That is what I said consistently when I got asked about Black Lives Matter protests, when I got asked about rallies for the president. But it was always, again, sent at you from a political angle. They didn't really want to know how people should stay safe. They wanted to get me on record as being for or against a particular person.
And the answer, you have a consistent answer, but it's the framing of it that is trying to get you. And
trying to get the headline.
Yeah, sure. I get that. So we want to work on that right here. No, no, this is not about that. So in that crucible experience, it's a season that's come and gone. Would you say that you miss that? I mean, you described just now for me a kind of like a bunker, and I mean that in a healthy way. You're fighting a battle against this COVID disease. You're meeting regularly with people that you name, Dr. Fauci, Dr. Birx, Dr. Redfield, that you respect, felt like we're good teammates. And now that team isn't meeting anymore. I mean, do you miss the camaraderie or the bonding that you had there? Or I'm glad that chapter's closed?
Well, yes, I do miss the camaraderie because you really do when you're in a trial like that. You come together, you learn about people and their families, and you really support one another. And all of those people who I named and more are friends. And so I do miss that. One of the things that I miss most, though, is I can't tell you how many times I felt like, and this is again where I felt like, okay, God wants me to be here. How many times I felt like if I hadn't been there, that perspective wouldn't have been brought to the fore. And sometimes, again, it was the perspective of rural or middle America. That way of framing something or that ask is going to fly very differently in downtown LA and what it's going to fly in rural Indiana or rural Montana. Sometimes it was the perspective of being an African American, and there were so many times that I was the only African American or person of color at the table. Sometimes it was the perspective, quite frankly, of being a little bit younger and being someone with kids who were still in school, because and especially in those high-level government positions, a lot of times it is people who are older, empty nesters, the kids are gone.
The impacts of the policy are not the same.
Exactly. And so I was one of the few people who was going through my kids aren't in school, and I'm more worried about their mental health than I am about the risk of them getting COVID. I also had the perspective of, again, my wife dealing with cancer and the dangers that other people presented to her when they weren't following precautions. And so I had a very different perspective on our need to protect everyone else around us. So that's what I miss, because I worry that particularly the voices of rural America, middle America, and many swaths of minority communities aren't necessarily at the table or getting that same voice that they did when I was there. And so I'm not there. I can't say that for certain, but I haven't seen much about or outreach to some parts of this country. And I worry that is, again, either intentionally or unintentionally happening on political lines.
You have surfaced this issue, Dr. Adams, about the inequities of the pandemic, healthcare per se, but in the pandemic that kind of comes front and center between communities that are minority communities. And I think most people have a comprehension of that debate. They may not agree with the analysis, but they understand, well, there are communities that are of color or they're minorities and they're in cities and they may not be able to get to the doc in the same way somebody else can. But you've also introduced alongside that the inequity of rural healthcare and access, and that both are challenges, and we can't just focus on one without the other. Tell me about that.
Well, I tend to look at diseases and think about risks and risk factors. And I think we have to be honest that some people are just more at risk than other people. I am less at risk for a lot of things, as are my kids, because I'm a doctor and I live in a nice neighborhood. My daughter was out riding her bike today. There are some neighborhoods, many neighborhoods in this country, where as a parent, you can't send your kids to go and ride a bike around the block your 11-year-old daughter. And so there are certainly risks that come with income. differentials. There's risks that come with being one race or another, and I think we have to have the courage to be able to have a conversation about racial bias without either accusing each other or feeling like we're being accused of being racist. That's another place where there's so much loaded language and stigma that it makes it impossible for many people to have a conversation. But to your point, growing up in rural Southern Maryland on an old tobacco farm, ironically enough, I very much appreciate the challenges that rural America faces. The lack of access to health care. First time I went to Washington, D.C. was in a medevac helicopter because I had a severe asthma attack and they couldn't take care of me.
You could not be treated at home.
At home. They couldn't take care of me and I would have died. And so I very much understand how care is challenged. And then after that, my parents would have to take off work and drive me, and it was a whole day that they'd have to drive me to Washington, D.C. for checkups at Children's Hospital in Washington, D.C., and that impacted their ability to generate income. That was extra stress financially and otherwise on their lives. There are challenges that come with being in rural America. There are transportation challenges. One of the big issues my brother now has, the one who has substance use disorder with treatment programs, is you can't just hop on a bus line or walk a couple of blocks and find a treatment center. A treatment center is 10, 15, 20, 30 miles away. And if you don't have a car, then you can't get treatment. But we don't think about necessarily access to transportation as being a major barrier to whether or not you're going to be able to recover from substance use disorder. So a lot of challenges that rural America faces. They were also hit particularly hard by the economic fallout of the pandemic. You had a lot of people just barely hanging on in the first place. What is a controversial topic, but is one we need to have a conversation about, is the fate of rural versus urban hospitals. Mm-hmm. Many urban hospitals financially actually are doing quite well because of COVID, because there's lots of money pouring in. And now it's not to say that the people aren't stressed, that the nurses and doctors and staff.
The staffs are under threat.
They're under threat. They're stressed. But financially, there's money pouring into some of these hospitals that are taking care of a lot of these COVID patients, whereas a lot of rural hospitals, they didn't get hit particularly hard with COVID, but they had to shut down, and they weren't able to do their elective cases.
The ordinary course,
the revenue. And you already had a crisis of rural hospital closures pre-COVID.
Anyway.
Pre-COVID. Yeah. And that's another challenge that rural America faces. The access issues are only going to be that much worse.
They're exacerbated through the pandemic. And you said racial bias. It's hard to have a conversation about racial bias without being labeled or maybe people are very guarded because they don't want to be misunderstood. But what do you consider to be, in terms of healthcare, racial bias? Or where is that evident?
Well, we see it in a number of places. So I'll give you a very concrete example. One of the last major publications I put out as Surgeon General was a call to action on maternal health, recognizing the fact that a Black woman or a Native American woman is 3 times more likely to die around the time of childbirth than a white or a Asian American woman. And this is after you control for education, after you control for income, after you control for where you live. It is the most glaring example in health that I can think of where there is a clear disparity in outcomes based on solely race. And it doesn't matter if you're Beyonce, who almost died giving birth, or if you're Serena Williams, who almost died due to pregnancy-related complications, or if you're Shalon Irving, who is a PhD-educated epidemiologist who worked for me, went into the hospital and unfortunately died due to pregnancy-related complications, African-American female. And so we need to have the courage to, first of all, look for these differences. And that's collecting data and then looking at the data. And then we've got to start to unpack, why is this occurring? Is it occurring because of neighborhood or income? Is it occurring because of lack of resources? Because in many cases, that is it. But we also have to ask ourselves, is this occurring because of bias in the system? And we found that from a maternal health standpoint, for instance, in many cases, Black women's concerns were being dismissed. If they said, I have abdominal pain, I've got a headache, I don't feel right, it was dismissed, it was blown off.
They might be in a hospital.
Exactly.
But not being acknowledged or not taken seriously.
Exactly. And so one of the things that the CDC did was put out a Hear Her campaign. One of the messages is simply hear her. But you also have to then go a little bit deeper and understand that thanks to decades, centuries of mistreatment, many people don't even feel comfortable speaking up. They don't feel comfortable, or they feel like it's pointless.
Not articulating.
Exactly. And so we have to create an environment where people know what to say and are comfortable saying it, and then are heard when they say it. And a lot of these issues, whether we like to admit it or not, are impacted by race, whether you feel comfortable speaking up, whether or not you're heard when you speak up. And so, again, that's not saying that you as a doctor, as a white doctor, are right. A racist.
Don't be stigmatized on that.
Exactly. It's saying, hey, we need to understand that when you're having an interaction with a patient of color, the things you say and the things that you hear are likely to be interpreted differently than if you're having a conversation with someone of a different color. We have to have the courage to admit that, yep. And then figure out, okay, so how can we move past that?
And that brings me back to your whole trajectory again. So here you are. I mean, Dr. Adams, you have such a grasp of so many dimensions of human life and experience right now. And that's consequent to the way which doors have opened. You've walked into them, but also has to go back to the beginning. When did you imagine that you might, in fact, be a leader, not necessarily a doctor, but that you might find yourself in command, as it were? Do you have a moment in your memory where you thought, man, maybe I'm going to be at the front of this line?
Well, what's interesting is that I always felt that I was being called to do something more so. I mean, I was in the gifted and talented programs growing up. I had a thirst for learning. What I would say is even more interesting, though, is similar to my wife being able to have access to cancer treatment because of something that initially was a negative. In many cases, I was not able to go out and play sports or do the things that other little kids do because of my asthma. And I saw that as a negative. But what did I do when I was inside? I was reading books. I was educating myself and finding joy in those different stories, using that as my opportunity to escape. Being poor, we never went on vacation when I was younger. I take my kids on vacation whenever I can, and to the point where they don't even want to go anymore.
Dad, don't make us go.
Well, truly, and it's just mind-boggling to me because we couldn't afford vacations growing up. And that was a negative, but the positive was my escape was through books and learning, and so that opened up other doors for me. But I always felt like I was called to do something in a leadership role. I just didn't know what that was, and I certainly at that time didn't think it was going to be as Surgeon General of the United States.
Something drew you to medicine. Now, again, I'm always connecting the dots to my own journey. It's probably not relevant, but I'm just going to tell you my story. So as I was growing up, I went with my dad once to visit a dentist in his home. My dad had some business or something with that guy, and I'll never forget walking into the house, and it was just like this amazing house. I thought, well, I'm going to be a dentist. And so then, I'm in the 8th grade or 9th grade, and I thought, I'll do that dental thing. But then I realized science is not my game. I'm certainly not going to make it. I'm not going to cut it. And we all navigate sometimes, don't we, through our dreams and ambitions and the things we think of in childhood. But then somewhere along the line, something lands. You must have had an avocation for science or biology or something where you thought, you know what, I want to get into that.
Absolutely. Thank goodness for my chemistry teacher, my calculus teacher. I really did have people take me under their wings and encourage me, and again, gave me the opportunities to go to summer camps. I mean, those were some of my fondest memories, and these weren't like Camp Kikiwaka summer camps. These were math and science summer camps. I went to the National Institutes of Health and learned about what it meant to work in a lab one summer. So I always knew I was going to pursue a career in the math and science route. I started off majoring in engineering, actually, because, again, it was very math
of course.
and science-oriented. And then ended up doing a lot of lab work, and I really enjoyed working in the lab. I enjoyed discovery. I enjoyed trying to figure out how we could make people healthier. And then I, again, met Dr. Carson, but I also worked with someone who was an MD, PhD, and I was working in his lab more on the research side, but I rounded with him in the hospital. And that's when I was like, wow, I kind of like this medicine thing because I get my math fixed, my science fixed, I get my solve problems fixed, but I also get to interact. And I'm someone who I think most people realize now is definitely a people person. I get my energy from being around other people, but especially from feeling like I helped other people. And so that's really where the medicine bug came from. And even interestingly, through medicine, even that wasn't enough. A TED Talk that I gave, I talk about a gentleman who I took care of, a young man in the hospital down the street, Eskenazi Hospital. And he came in, multiple gunshot wounds, and I'll never forget him because he was cursing, yelling, screaming, belligerent. Again, you can't judge a book by its cover. You don't know what people have been through. And right when I was putting him to sleep, he grabbed me by the hand and he said, "Doc, please don't let me die." And I remember looking at him and saying, "I'm not going to. We're going to get through this. You just hang in there." And we worked on him all night. And again, short version of a long story, he made it back home. Well, about a year later, he came back in and he'd been stabbed.
Oh, my.
And so we patched him up and we took care of him again. And then he came back a third time, shot again. And
do you recognize him each time? I mean, you see lots of patients, but you think, oh, I remember you.
Oh, absolutely. And when we see the people who were on that revolving door.
Yeah.
And so I realized that being clinically excellent wasn't enough. You can't just put a Band-Aid on someone, even if you're the best Band-Aid putter-oner in the world, and think that that's going to change people's outcomes. And that's what really pushed me to try to figure out, can I change policies? Can I get in a position where I can provide care for thousands, tens of thousands, millions of people at once? And we did that with the naloxone advisory. I could administer naloxone to an individual and save an individual life. I put out an advisory of Surgeon General that went all across the world and that perhaps, again, has saved tens of thousands of lives. And so certainly I have always sought out opportunities to try to help other people. That's something that's just been a part of me. Another funny story, and I love to talk about my kids. We drove by a house today, my daughter and I had to pick her up for an orthodontist appointment before I came here. And we drove by a really nice house. And I said, one of my former partners lives there. And she said, "Are you sad you don't have a house like that, Daddy?" My daughter asked me that question, and I said, God has given us enough to be very happy. And when I meet God, I'm going to have to explain to God what I did with the gifts and the opportunities that God gave me. And I think God's going to want to hear more than how nice my house was or how nice my cars were or beyond. And I said, and so I'm okay giving up the really, really nice things as long as I can create a nice and comfortable life for you all. If it means I have an opportunity to be Surgeon General of the United States and to have a larger impact on people's lives.
That's brought up this still frame of you speaking there, and you're describing a calling, Dr. Adams. You have a profound sense of what I would describe as providence calling you somewhere. And that speaks also to a faith journey of some kind. You're not just random forces in this world. You have a knowledge of a God, a personal God. So tell me a little bit about that. How did your faith journey form? And then how does calling speak into things? But let's start with a faith journey.
Well, I grew up in a very staunch Catholic family. A lot of people don't realize that Maryland, and particularly Baltimore, Maryland, is kind of the Vatican, if you will, of the United States.
It's Maryland.
Exactly. And so my grandfather and all of my uncles were members of the Knights of St. John, which is a Catholic organization. And we went to church religiously. My father is still, he still calls me now during Lent. You going to church on Friday? It's Friday. It's Ash Wednesday. Don't forget to go get your ashes. Mm-hmm. Make sure you don't eat meat this Friday. I mean, still, I get those calls.
He's very deep in. Yes.
Exactly. And so that is a lot of where it came from. I'm going to be honest, though. Though I have fond memories of a lot of it, the Catholic Church was and is very ritualistic. And so a lot of it was lost on me growing up. It was go through the motions. But just like playing baseball or playing basketball, sometimes you do have to go through the motions and have a routine before you really understand and see it all come together. And my wife and I, she grew up Pentecostal, which is very interesting when you bring a Pentecostal and a Catholic together.
A little of a distance across the street from the Catholic tradition.
So we split the difference and we go to a Methodist church.
There you go.
But throughout it all, I still have a deep belief in God as a higher power. I still believe very much in Jesus and what he taught us. And one of the challenges I often have in life is the whole Old Testament versus New Testament. It seems like people want to be treated in a New Testament way. You should forgive me. Jesus wants you to forgive me. But they want to treat others in a very Old Testament, fire and brimstone, yes. I will inflict wrath upon you type of way, eye for an eye type of way. And I think that is a challenge that we all have in our faith journeys, is trying to figure out where that balance lies. But it was very important for me to have that grounding in terms of where I am right now. I don't think I would have made it through my time as Surgeon General if it weren't for my faith, because there were so many times that I felt set upon from all sides, where I felt like, why am I here? I'm doing the best I can to help people, and the people who I'm most trying to help are the ones who are most viciously tearing me down. I mean, I saw a side of people and human nature that was quite frankly shocking to me when I was Surgeon General. Even yesterday, the comment, we talked about the conversation on CNN, a scientific conversation that I was trying to broker about whether we should have 1 dose or 2 doses, which a lot of scientists are talking about, and just the horrible things that people felt it was their right.
They have a license to say.
Their license to say to me. And I just always remember those Bible stories that I was like, eyes rolling in the back of my head when you're hearing them and reciting them over and over and over again when you're younger. But they're back there. And you think about the fact that there is not a hero in the Bible who didn't face terrible challenges, who wasn't even sometimes by his own family criticized, beat upon, ignored. And so, I also tell people I am very spiritual. I am a Christian, but I also try to be very careful about not being heavy-handed with my Christianity. And Christians, it's interesting because there's debate about that too. And you lead a large flock of people, and every so often during the year there's a sermon about your job as a Christian is to go out and convince other people and to talk to other people. But if I'm going to be honest, as many other people, you feel a guilt out there trying to, you don't want to go out and try to put yourself forward as holier than thou. And you don't feel worthy, quite frankly. And I've had a lot of challenges in my life. There are a lot of things that I'm not proud of that I've done. But one thing that I do try to do is just keep getting up and doing a little bit better, learning from it and continuing to do a little bit better. And I hope that is an example to someone out there, because one of the great things that I think God has also given me is the ability to kind of see and meet people out there who affirm that, hey, you're not alone, and people are watching you walk through your struggles. And in many ways, it's helping them have the strength to walk through their struggles.
Well, I think it was Francis of Assisi who's quoted in some way, I'm paraphrasing, you need to bear witness to the truth, always. And if necessary, use words. But we tend to run to words as the first demonstration of our faith, when actually people watch who we are. And I think Jesus was a master of words, but people also saw who he was. But that leads to a sense of calling, and calling suggests a kind of providential plan. If God calls me, and I will tell you, I believe that I was called into my journey. As I said, I dreamed of politics, but I actually did a little time in the State House in Washington State. But the Lord called me out of that into the ministry. So I'm a believer in that. I've seen you quoted in such a way that makes me think you also are. Help me understand your view of that. God has opened up doors for you. You have walked into them. How do you understand that calling, and what do you think is calling you next?
Well, I'm currently jobless. And I'm thinking about what comes next for me. And I think that calling, and it's interesting because as a dad, I try to communicate that to my children too. And I struggle, and my teenage boys especially don't want to hear it right now. But I really do believe God gives each of us unique gifts and talents. And then God wants us to use those talents to impact the world and other people's lives in a positive way. And for some people, it's an amazing sports talent. And I want you to be a great basketball player, but I want you to use your basketball skills to go around and help other people understand the way they might live their lives. And you have some basketball players out there who've done a fantastic job of using their bully pulpit. For me, it's continuing to find out how I can have that impact. And as a dad, and you'll get this, it's hard with kids because this whole nature versus nurture thing that we learned about, my kids grew up in the same house and they could not be more different. And it'd be nice if we could just have one plan to parent our kids. Yes. But one of my kids, is great in school, very athletic, and is trying to help him understand God's given you these talents, but you can't just sit on them. You have to continue to hone those talents, and then look for the opportunities, the doors that are going to open up, because they're not going to just open up if you sit there and wait for them and do nothing. I have another kid who hates sports, but he's an outdoorsman. He's got a big heart, and it's really and he also struggles in school. He's ADHD, but it's trying to help him understand. Okay, we aren't expecting you to get straight A's. We want you to do the best that you can, and we want you to be happy and to figure out where God's calling you. And then you've got to, with all the kids in a room, watching how you treat one versus the other, and getting sore because you did this for one and not for them. Explain to them that I'm treating your sister this way and your brother this way because that's what they need, and not necessarily treating everyone equally. It's interesting, and one of the things that I often talk about is there's a difference between equality and equity. And equality is giving everyone the same thing. Equity is giving everyone what they need to be successful. And I think that's one of the internal struggles of being a parent, but it's also one of the one of the struggles we have in our faith journeys.
Absolutely. Just navigating with equity is more difficult than equality sometimes.
Exactly. So my hope is that whatever job I take next, I will be able to, in a different way than when I was Surgeon General, but when I was State Health Commissioner, I was an anesthesiologist, and I literally saved lives. I saved that young man's life. He would not be on this planet right now if I hadn't been there taking care of him that night. Then I became the State Health Commissioner in Indiana, and I was able to move money around and programs around and change opportunities for health for people. Then I became Surgeon General, and I was able to use my bully pulpit to change the way people think about certain issues and to destigmatize things, because by golly, the Surgeon General says it's okay to carry naloxone.
Right.
And so now, again, it's trying to figure out where God is calling me to use those talents and skills to have an impact in people's lives in as powerful a way as I can.
I have no doubt that there's another chapter for Dr. Adams.
I hope so.
Of great influence. I have to ask, though, your specialty is in anesthesiology.
Yes.
How did you land there when you might have gone another direction?
I actually started off in internal medicine. And your internal medicine doctor, your family practice doctor, that's who we think of as primary care doctors. They're the ones you see when you've got a cold, when you've got a fever, or when you need your high blood pressure treated. And I still enjoy that. I enjoy it very much because you form relationships with people. But I am also, as my wife puts it politely, a busybody. And one of the challenges with internal medicine is that if you come into my office and you have high blood pressure, I go, tell me about your diet. Tell me how much you're exercising. Okay, go home, exercise more, eat better, come back in 3 weeks. 3 weeks you come back, you still got high blood pressure. Say, okay, we're going to put you on this pill. This is the starting dose. Go home, come back in 3 weeks. 3 weeks you come back, and so on and so forth. And it may take me weeks to months to years to get your blood pressure under control. As an anesthesiologist, if I'm in the operating room and your blood pressure's high, I reach into my little drawer, I pull out a syringe, and I inject 1 cc. And if your blood pressure isn't lower in 30 to 60 seconds, I inject another cc. And by golly, within 5 minutes, I have your blood pressure
solved,
under
done.
control. Exactly. And so I like that immediate feedback. Mm-hmm. I like the breadth of anesthesia too. There are days when I've worked at the hospital down the street from us that I talked about, Ball Memorial, where I've taken care of a 6-month-old in the operating room, and then I've taken care of a 96-year-old with a hip fracture. Yes. And so much variety too, hands-on and a real variety. And in a weird way, you have a powerful opportunity to impact people's lives in anesthesia, because there is not a moment in many people's lives when they are more scared
or vulnerable
than when they're coming in for a surgery. The medications we give you to keep you asleep during surgery are the same medications they use to execute people. And I
feel better now.
Thanks for that. I don't say that to scare people much as I say that to help people understand that we are literally bringing you to the bridge between life and death and keeping you alive while a surgeon cuts on you and does something that you would never be able to tolerate while you're awake. And then we bring you back. And it's a powerful opportunity to talk to people about quitting smoking. Anesthesiologists do epidurals. I will often talk to the people in the room with the mom when I'm putting in the epidural, because you can smell the cigarette smoke when you come in the room, about, hey, have you ever thought about quitting? It'd be a good time with a new baby coming in the home. And you find a way to do it
right.
gently, politely, not shaming them. But you're much more likely to have success in that environment than you are in many other environments out there where people don't have that motivation, that immediate focus on their health.
Well, Dr. Adams, I'm going to suggest to you something that you put in my mind earlier in the conversation when you said at Ellis Island, there were public health officials who were screening immigrants to the country in 15-second physicals. And I'm saying, if you open a practice like that, 15 seconds, there's a crowd outside the door. You could do 15 seconds. But before we let you go, Dr. Adams, let's go back to the COVID-19 pandemic, which has defined so much of your public persona in recent days. Tell me, you and I are in this room. We're isolated in this room, and both of us talked about this before we sat at the table, that we've been inoculated. But should I still be wearing a mask? Should we still be wearing masks? What do you say?
I say that we should still be wearing a mask when we are out in public again. And I want people to understand that you and I had a conversation. We both had our vaccinations. We still are a reasonable distance apart. We've got good ventilation in our room. Everything is about a risk continuum. Mm-hmm. And there are certain things that increase your risk of getting or spreading COVID. And there are certain things that decrease your risk of getting or spreading COVID. And what I tell people is try to do as many things as you reasonably can to lower your risk. You and I are trying to do a podcast where we want people to be able to hear our voices. And so we looked at the downside of us wearing a mask versus the benefit. And we made a decision based on the other things that we're doing to mitigate that risk to not wear our mask. And so it's not a always or never. And I think that's something that's lost on people because people want an easy answer, and it's hard to communicate nuance. But at the end of the day, we still want people when they're in public around other people to wear a mask.
When you can't have the conversation and sort out all the risks, wear a mask.
Exactly, because if you and I were to run into each other at the grocery store and neither one of us knew each other, I wouldn't know if you'd been inoculated or not. There's also the symbolic nature of wearing a mask, and
it says something.
And we have our mask with us. And if we were out in public and when we were around other people earlier, we wore our mask because people need to see that. So there's the symbolic part of it. There's the scientific part of it that we still don't know for sure. That these vaccines are going to be as effective at preventing disease spread as they are at preventing hospitalization and death.
And protecting us.
Exactly.
May not mean I can't still be a carrier.
Exactly. And then there's the risk-benefit equation.
Okay, so the last question, of course, the obvious answer. People should get this vaccine. If you have the opportunity to get a vaccine, take one. I say it's obvious because you and I both did that, but...
I had a wonderful conversation with the Pastor Johnson of Eastern Star Church, which is a
big church in Indy.
Big church in Indy, just last week, and we talked about this story that I love about the man who was in the boat, and hole in the boat starts going down. Someone sees him. They come over and they say, "Hey, do you need some help?" And he goes, "No, God's going to save me," and sends him away. And the boat gets a little lower, and another person comes over. God's going to save me, and so on and so forth. And the guy drowns, and he's at the he's at the pearly gates talking to St. Peter, and he goes, "Hey, what gives? What happened?" And he says, "We sent 3 people out there to save you, and you kept sending them away." And I tell that story because I want people to understand these vaccines. Not just the COVID one, but other vaccines out there too. They are gifts from God. It truly is a miracle when you look at the number of lives that have been saved by vaccinations and the fact that we can end this pandemic if we get our vaccinations. But it only works if we choose to take them. And so incredibly important that we take them. I got mine on live TV because I wanted people to see me walking the talk. Yeah. And I actually worked with the companies, saw the studies, know the inventors of the vaccines. I believe they are incredibly safe. some frequently asked questions. You cannot get COVID from the vaccines because we're not giving you the virus. There's the mRNA vaccines, which are just the instructions to the virus. And then the new Johnson & Johnson vaccine is not the COVID virus either. It is an inactivated adenovirus, which is the virus which causes the common cold. And it then produces the protein so that your body builds antibodies. But you cannot get COVID from this. And right now, there have been far more hospitalizations, complications, death from COVID than
from the vaccine.
Talk
about risk mitigation.
Exactly. And so it's all risk benefit. There you go. So funny thing in that picture right there, everyone is the first thing people said when they saw that picture, what do you think it was? They thought I was flexing.
Well, I mean, come on.
They thought I was flexing.
You're looking good there, Dr. Adams.
I think I was just nervous because I was about to get a shot on live TV and I didn't want to squeal.
But I thought that's just your relaxed arm. Come on. So glad to have you here. Thanks for, again, all you've done for the public good. And know that our prayers are with you for that next chapter. I know the Lord has a calling.
Well, thank you. And I ask you and anyone who feels so inclined to pray for me, to pray for my wife and my family, and to pray for all the public servants out there who are making very real sacrifices to follow their calling. And one of the things that I feared is that COVID will discourage many people from following that calling. Yes, and so we need to understand that individuals are called, but people and communities serve. And one of the ways that you can serve is by supporting other people who have a calling to go and do some of these difficult things on the front line. So thank you for the opportunity to be the United States Surgeon General for the last 4 years. Thank you for the opportunity to have this conversation with you in a little bit of a longer format today, because I hope people get to have a little bit better of a picture of me than that caricature that maybe they were carrying around in their mind.
Well, I'll just say, I didn't, Vice President Pence did not call me up asking about whether he should call you to be the Surgeon General. But if he had, I'd say, you go for that guy. He is the finest. Thanks, Dr. Adams.
Thank you.
Godspeed.
For more information, visit allthattosay.org. Thank you for joining the conversation. Don't forget to like and subscribe.